Welcome everybody, and thanks for coming. It's great to have you here, and I'm thanking you for spending some time in your evening coming to this seminar so we can go over a bunch of this stuff and save some time in clinic. So, benign prostatic hyperplasia is why we're here. We do want to encourage open dialogue amongst everybody and be able to use that chat option, so no recording or no recording this, but we are going to record it, and if you wanted to share it with friends, it's going to be available on my website, this whole webinar, so feel free to check it out again. It should be available within a week or two on my website, along with my other videos, okay? Again, I'm part of the SLUCare physician group. That's how we got most of your names and numbers, so you should be familiar. If you're interested in scheduling an appointment about any of these treatments, you can call either this number here or the SLUCare Central Scheduling, which is 977-4440. As you know, I treat all sorts of urologic conditions. I'm a general urologist, but one of my specialties is BPH. So what we're going to cover is we're going to kind of go over the prostate, what it does, where it is, why it's such a problem. Go over BPH, and then we're going to go over some treatment options, which is probably why you're here. So what is the prostate? The prostate, when it's normal, is about walnut-sized. It's a gland at the base of the male bladder, as you see here. This is the bladder. It's made of muscle and then a lining called the urothelium. The urine is stored in the bladder, and then when it's time to go, the bladder muscle will stretch. It'll send a signal to the brain telling it it's time to go. The brain will then send a signal to the bladder when you're near a toilet that it can go. The bladder will squeeze and push the urine through the prostate and the urethra. The urethra runs through the middle of the prostate. The prostate surrounds it. And if the prostate's pushing on the urethra, obviously it causes some what we call bladder outlet obstruction. The prostate, what it does for you, it actually produces some fluid that makes your sperm able to penetrate an egg. So that's its actual job. It also helps with ejaculation. It will squeeze during ejaculation, and therefore the semen will come out of the urethra and not back up into the bladder. The prostate will grow to its normal adult size in men, most men in their early 20s. However, it starts growing again during the mid-40s for most men. That's why BPH is such a problem, because it affects so many men, and it's part of just a naturally growing prostate. So what can happen to the prostate? You can get enlarged prostate, or what we call benign prostatic hyperplasia. You can get prostatitis, which is like an inflammation of the prostate, and you can get prostate cancer. These are all the things that we treat as urologists, and I'll kind of go through them. So BPH overview. What is it? It's commonly known as an enlarged prostate. It just means that it's grown larger than normal. Like I said, this occurs with age. It's a natural process. It is a benign process, meaning that it is not malignant. We'll go through that in a minute. The normal adult size is about 1.5 inches in diameter. Like I said, a walnut. If you work in centimeters, it's about 1 to 2 centimeters on each side, so maybe 2 to 3 centimeters wide. 20 grams, we tend to talk about grams in urology, so if your urologist said your prostate was 30 grams, that's pretty normal for a man over 40 or 50 years old. Benign prostatic hyperplasia or prostatic enlargement, it can lead to bladder outlet obstruction like I showed you before, and that can cause lower urinary tract symptoms. How is it related to prostate cancer? Like I said, it's not a malignant process. It's not prostate cancer. It does not cause prostate cancer, but prostate cancers that do have cancer is basically cells that don't stop growing and then don't die. So you can get an enlarged prostate because of prostate cancer, and therefore cancer can have similar symptoms to BPH. So that's usually why when you come in to see the urologist for BPH symptoms, we're going to recommend screening you for prostate cancer. You might have patients where they have BPH and prostate cancer, where their prostate cancer isn't really causing a lot of urinary tract symptoms, but their enlarged prostate is. Prostate-specific antigen is the PSA. That's the blood test that we use to screen patients for prostate cancer. Although PSAs can be elevated just from an enlarged prostate, they can be elevated from inflammation or infection. It can be elevated just from having an orgasm recently or any sort of anal stimulation like a colonoscopy. So BPH can cause elevated PSA levels, and so can prostate cancer. The only way we can distinguish that is by doing a biopsy, or nowadays we have MRI. So here you can see a normal prostate versus an enlarged prostate. As the prostate enlarges, it can put pressure on the urethra, as you can see here, and that can cause lower urinary tract symptoms. The prostate size doesn't necessarily correlate with the degree of obstruction or severity of symptoms. So I have lots of patients that have a normal sized prostate but come and see me because they're having lower urinary tract symptoms. I also have plenty of patients that have a very enlarged prostate on their CT scan or an ultrasound, but they don't have any urinary symptoms at all. So size doesn't necessarily matter in this game. You might have an enlarged prostate with no symptoms at all. So I do have a fair amount of patients who get a digital rectal exam from their primary care physician, and they tell them, oh, you have an enlarged prostate. They come see me because they're worried about that, but I ask them about their symptoms and they have no symptoms. So if you have no symptoms and you just have an enlarged prostate, then we're not necessarily needing to do anything about it. So what are the symptoms of BPH? There's frequent urination during the day and or during the night. We call that nocturia when it's at night. There's also the sudden urge to urinate, so we call that urgency. You might notice that you have a weak stream or poor flow of urine. After you're finished peeing or voiding, you might feel like your bladder doesn't empty all the way. You might have burning when you pee. You might have a stream that starts and stops all the time. You might have an inability to urinate, or what we call urinary retention. Some patients experience hesitancy as well. That's where you get the urge to go, you run to the bathroom, you're standing there over the toilet and nothing comes out. We call that hesitancy. Other people get what we call dribbling, which is after you pee, you dribble urine out of the urethra. These are all things that can be caused by BPH. There are other causes of some of these things too. And especially an overactive bladder could be the cause of having to pee frequently or go urgently. So when you come to my office, we try to figure out how much of it might be overactive bladder versus a prostate problem. An enlarged prostate over time will obstruct the bladder so much that the bladder muscle gets thickened. And as it gets thickened, guess what? Thick muscle doesn't stretch very well. So when the bladder stretches, when the bladder is full, it sends a signal to the brain, hey, it's time to go. The brain's like, hey, wait a second, we're not near a toilet, so you need to relax, bladder. The bladder's supposed to relax. It does, but guess what? Now that that muscle is thickened from years and years of pushing that urine through that prostate, it can't stretch. So guess what? It sends a signal 2 minutes later, hey, brain, no, I gotta go. We gotta go now because there's no more room in here. And that's how BPH can affect your bladder over time, eventually causing the bladder to actually have what we call diverticuli, which are outpouchings of the bladder, or cause the bladder muscle not to work at all. So there are some patients who have no symptoms, however, they're not emptying their bladder at all, and they're losing strength of their bladder, and that's when we need to intervene, and those are the things that we need to prevent by intervening. Can BPH affect quality of life? Yes, it can. So 95% of guys say they don't want to live like this anymore. 49% say they experience sexual problems as that's associated with their lower urinary tract symptoms. 51% that it interferes with some aspect of their normal life. And then it can also affect partners' quality of life. Who gets it? It's the most common for men over 50 years old. So for instance, 50% of men by age 60 will have the problem. 90% of men by age 85 will have the problem. In 2010, as many as 14 million men in the US had lower urinary tract symptoms. What are the risk factors? What can you do to try to reduce your risk for this? Well, if you're obese, you can lose some weight. Higher body mass index actually does cause, we see a little bit of this BPH problem, and it may increase your risk. Lack of exercise also increases the risk. But really the main risk is just aging, and there does seem to be a genetic cause of this. So if you have a father who had an enlarged prostate, it is pretty likely that you might as well. So how do we diagnose it? When you come to the office, we'll take your medical history, we'll ask you a bunch of questions about how you pee, and we'll do a physical exam. The physical exam might consist of doing a digital rectal exam. That's where we put our finger in your anus and feel the prostate through the rectum. A lot of people get confused. They'll say, well, I just had a colonoscopy. Why do you need to do this? Colonoscopy is looking at the wall of the rectum for any growths. When we put our finger in, we're actually feeling through the rectum to try to get to the prostate on the other side. And we're feeling for any lumps or bumps that might be tumors. And we're also checking size. It doesn't give us a ton of information on the size because we're just feeling the back of the gland. We don't know if the prostate grows up into the bladder. We don't know if it's growing forward, or we only know how wide it is. So it gives us a little bit of an idea, but it's not perfect. We also might have you pee in a machine called a uroflow, and that'll tell us how good your flow is. Does your stream start and stop? It'll also tell us how much you actually peed out. And then we scan your bladder and see if you're actually able to empty. So some people have post-void residuals, which is what's left in the bladder after you pee. Normal would be anywhere from 25 to 50. Over 100, that's when we start getting worried. We will give you probably some questionnaires or some things to fill out. My favorite is the American Urologic Association Symptom Score. It's a score that gets you up to 35 points, and it asks you things like frequency, urgency, how many times you get up at night, do you strain, do you feel like you empty your bladder? And you give us a score of how frequently you have these problems. That score is how I follow you through any treatment that we do, either medications, behavior modifications, or surgeries, because that's how we can objectively see if your symptoms are getting better. That's why you're here to see me, so we can improve your symptoms and improve your quality of life. Most of those questionnaires we give you do give you quality of life questions. I was going to give you a sample of one, but it didn't really work there. So anyway, treatment options, that's why you're all here. As you can see here, we go from less to more invasive. The less invasive things, which I'm a big proponent of, if we can fix your problem just by changing some things you do every day versus put you on a new medication or a pill or take you to surgery, I'm all for it. So we might talk about fluid and diet changes. One of the best things you can do for peeing at night is stop drinking about 3 hours before bedtime. Also get your legs up a little early if you get that swelling of the ankles at the end of the day. Most of that stuff is diuresing. When you age, you make more than half of your urine at night. So if you're saying, gosh, I really pee so much more at night than I ever used to, that's probably right, because that's what your body is doing. It's making more urine now at nighttime. So most people over 65 are having to pee once a night. Another thing you can do is look at your caffeine intake. And if you're drinking a lot of caffeine, that might be causing some of the frequency and urgency, that rushing to the bathroom and going frequently. So I usually tell any patients that have prostate problems that they should probably give up caffeine just for a week and see if some of that urgency and frequency goes away. If it does, then we might need to look at limiting how much caffeine you drink every day. Watchful waiting is doing these kind of things, these behavioral modifications, and seeing how long we can prevent giving you some sort of a treatment for it. We can also do bladder retraining, which is when you get that urge, you distract your brain, try to get that urge to go away, and that way you can go a little longer between urinating. Kegel exercises will also help. If you don't know what a Kegel exercise is, that's where we flex our pelvic floor muscles. So your pelvic floor is what holds all of your insides up. If you're obese, that pelvic floor is probably getting stretched out because it's holding up all of that weight. So if you're obese, it's a really good idea to start doing Kegel exercises. I tell all of my prostate patients to try to do Kegel exercises, especially if we're about to do any sort of procedure on them. How you can do them is by squeezing to try to stop the stream of urine. So if you were standing on the side of the road and you were peeing and a cop came up and you had to stop, that's a Kegel. The other way to think about it is think about a finger in your anus or in your, forgive me, but butthole. You can put your finger, pretend like there's a finger in there and squeeze. So everybody do it with me right now. You can squeeze those muscles. You might feel that the pelvic floor is lifting underneath you. That's a Kegel exercise. So you can do squeeze, release, squeeze, release, squeeze, release 10 times, 3 times a day. You can also do it where you squeeze and hold and try to keep holding it, keep it tight, and then squeeze again, get it a little tighter. Do that for about 10 seconds. And that's so if you're rushing to the bathroom and you need to hold your urine, you can make it to the bathroom that's 10 to 15 seconds away. So those are Kegel exercises. Those are all things that you can try, and that might improve some of your urinary symptoms enough that you're not so bothered that you require medication or a procedure. Then we move into the first line therapies. So BPH medications are one, permanent implants, Rezūm Water Vapor, and then the surgical procedures. And we're going to go through all of those. A lot of my patients ask me about alternative medications or supplements or herbal remedies. There is no dietary supplement or herbal remedy that we've studied in evidence-based medicine that is proven to give long-lasting reduction of symptoms. I have had plenty of patients do well with soft palmetto. There are a few studies out there that show that it does work. I always just recommend to have a little caution when you are buying supplements, that supplements are not FDA approved. And I believe supplement companies are out there to do good by patients, but they could be just rolling one over on you and just giving you a sugar pill. So if you are going to buy supplements, try to find ones that are regulated by supplemental regulators. Go to the next one. So watchful waiting, we kind of talked about that. You know, only 19% of guys were satisfied with this. For me, I tend to see it with patients who have that urgency and frequency with caffeine, and making that modification might do the trick. Obviously, no general anesthesia, no permanent implant, no surgical retreatment. However, the potential side effects of doing this might mean that, you know, as your prostate grows, your symptoms might get worse. So you may need an intervention later. One of the first lines is an alpha blocker. You might be on it or might have been put on it before. Tamsulosin, alfuzosin, anything ending in osin, or what we call Flomax. What it does, it helps relax that bladder neck, that bottom part of the bladder, and the prostate. It relaxes those smooth muscle cells so that the prostate opens up, and therefore the urethra opens up, and you can have your urine flow more freely. This says 71% of patients stop taking their medication within a year. I'm not sure that I see that. Most patients are pretty happy on it. However, it does have side effects. You might have a drop in blood pressure, dizziness and or fainting, fatigue. We usually tell you to take it at night because it does make you a little sleepy sometimes. It might have interactions with other drugs or medications, which there aren't that many that it actually interacts with. And then the main side effect is 17 to 25% of men get retrograde ejaculation, where when they orgasm, nothing comes out. And that's because the prostate can't squeeze anymore and the bladder neck can't close. So you still ejaculate, it just goes up in the bladder and then you pee afterwards. Again, no general anesthesia, no permanent implant, no surgical retreatment with medications. The other medication is a 5-alpha reductase inhibitor. This is finasteride, dutasteride, or Proscar, or what's the other brand name? Proscar or Avodart. So you might have been on these. They actually stop the symptoms by shrinking the prostate. It shrinks the prostate by a third. The candidates for these medications are people with prostates over 40 grams. So you have to have a pretty large prostate for this to work well. What it does is it stops the production of dihydrotestosterone, which is a male sex hormone. And therefore, you might notice that when you take it, you get a lowered sexual drive or difficulty getting erections. It does lower the PSA level to 50%. So usually if you've been on it for 6 months, we need to, when you get your PSA test, multiply it by 2 to get the actual level when we're looking at screening you for prostate cancer. Most people tolerate this medication well. One of the biggest problems with it is it takes 3 to 6 months to work. So you're not going to take it and notice the difference right away. It's going to take time. We have shown studies that using the alpha blocker and the 5-alpha reductase inhibitor, that'll take that AUA symptom score, which can be as high as 35 for severe patients, and bring it down about 9 points. So if your symptom severity is very high, this isn't really going to do much for you. It's going to get you down to 26 points, which is still pretty bad. If you have a symptom score of 12 and it brings you down 9 points, then that's pretty good, because you're walking around, you might have one time during the day when you pee frequently and one time when you rush to the bathroom. So it does depend on your symptom severity on whether or not we're going to start you on these pills. The next first-line treatment is Rezūm Water Therapy. What is it? It's a non-surgical outpatient therapy. It uses the natural energy stored in water vapor to shrink excess prostate tissue. We don't require general anesthesia for this. If you're scared about having something go up the urethra, we can give you a Valium, which makes you kind of drunk like you don't care. We can also give you a narcotic. There is no permanent implant for this, and there's a 4.4% surgical retreatment in 5 years. So we do have studies out there that show that however you are peeing at 90 days usually lasts 5 years, which is pretty good. The potential side effects are obviously some pain or discomfort after the treatment. That can last up to 30 to 90 days. So the first month to 3 months while your prostate is reabsorbing that tissue, you do have some discomfort or some urgency frequency. You might see some blood in the urine or blood in the semen, and that's just a side effect of the procedure. Usually that goes away within a week or two. So here is a picture of the prostate before and the prostate after. As you can see, the urethra is wide open there. I'm going to play a little video, and it'll hopefully you can hear it.
Rezūm uses the natural energy stored in water vapor or steam. Clinical studies support that Rezūm relieves BPH symptoms safely and effectively, eliminating the need for BPH medications, while also preserving sexual function. During each 9-second treatment, sterile water vapor is released throughout the targeted prostate tissue. When the steam contacts the tissue and turns back into water, all the stored energy is released, causing the cells to die. Over time, your body's natural healing response absorbs the dead cells, shrinking the prostate. With the extra tissue removed, the urethra opens, reducing BPH symptoms. Most patients begin to experience symptom relief as soon as 2 weeks, and maximum benefit may occur within 3 months.
There you go. And yes, you can go to rezūm.com and see more patient testimonials, such as this guy, and watch that video again if you want. 97% of patients will refer their friends to getting Rezūm, and I will say most of my patients say that as well. I'm going to go ahead and fast forward because this is a 3-minute video. Like I said, you can go watch it yourself, but we'll start here where he starts talking about the actual.
I decided to go ahead with Rezūm because I had looked online and saw that there were side effects with drugs or some of the surgical procedures that I didn't want to go through. And the procedure didn't last that long. I was surprised. I thought it'd take longer, but it didn't. Everything was done in the doctor's office. I mean, they didn't have to go to the hospital or any of that. And I actually drove home, so it wasn't a bad thing at all. After having the procedure where I am now 5 months later, I mean, it's just totally different. I have no problems whatsoever. I sleep at night. I still get up once in a while, but I had nothing like before. I would get up many times a night before to go to the bathroom. Don't have any of that now. It's back again like I was literally 30 years ago or something. I have already recommended it to other people. I said it's the best thing I've done, and I wouldn't wait. Why wait? It's not going to get better. So you need to take care of it in some way, and this is, I just can't recommend it enough. I mean, it's just so different, it's unbelievable.
So like I said, you can watch the full video online, or you can go see other patient testimonials online as well. A few more things about Rezūm. I do require about 25% of men will go into retention, meaning that they won't be able to pee in the first 7 days after the procedure. So we'll either teach you how to perform straight catheterization, which means that we teach you how to put a catheter in your bladder in case you can't pee. That's just so that if it happens in the middle of the night where you get up, you can't pee, you're not ending up in an emergency room when I'm not available. So we teach you how to straight cath so that if that happens to you, like I said, 25% of the time, not that often. I think I've only had 2 patients that's happened to. You can get yourself out of trouble without having to go to an ER. The other option is if you don't want to cath yourself, we'll just put a catheter in and you wear a catheter for 7 days, which most of my patients actually haven't minded. Those first 7 days are a little rough anyway. You're peeing very frequently. You're having a lot of urgency, going to the bathroom a lot. You might have some blood in the urine, and the catheter just kind of prevents all of those things and makes you a little more comfortable for that 7-day period. So it is all done in my office. The whole visit, it takes less than an hour. We do put a scope in your urethra. We will numb up your prostate prior to the procedure with doing a rectal ultrasound, and then we'll also numb up your urethra. Most people still feel it, and I would say the majority of men just kind of take deep breaths during the treatment. Each treatment is 9 seconds, and that's when you're going to feel something like a bladder spasm or a feeling like you have to pee. You might feel some heat down there. But most people just kind of get through the 9 seconds. We usually do about 2 treatments on either side. So it's 4 treatments that are 9 seconds long. Most of the people I've taken care of. I've never had somebody jump off the table, kick me, scream, anything like that. So most people tolerate it just fine. When we are done, we take the scope out and you're able to just walk out of the clinic. If you do decide to take a narcotic or a Valium beforehand, I make you get a ride just because you shouldn't operate heavy machinery when you take those medications. So that's pretty much the Rezūm treatment and how we do it at our office. The next one on here is the Prostatic Urethral Lift. This is another outpatient procedure. Some urologists offer this in the office. I actually don't offer it in the office just because I don't have the special scope we need for it. So we do take you to the operating room. If you are in the operating room, you can have no anesthesia, or if you prefer to have anesthesia, we can give you what we call light anesthesia or monitored anesthesia care. There is a permanent implant that goes in. These are just little implants that go in and kind of lift the prostate sides up so it opens up that urinary tract. There's a 13.6% surgical retreatment through 5 years. And when I was talking about that AUA symptom score, this brings it down about 9 points. So I usually save this for patients who do really well on their medications and just don't want to take pills anymore or have side effects from them. The Rezūm, however, it actually reduces the AUA symptom score by 50%. So that's a pretty good, and on average 15 points. So it kind of depends on where you are. I have had patients go from 35 all the way down to 1 or 2. So there is all sorts of ranges through Rezūm. Prostatic Urethral Lift, I pretty much see anywhere from 9 to 15 point reduction. So it's pretty good. And again, lasts 5 years. And it's pretty easy to go through. When you wake up, we usually don't need a catheter, and you're noticing that improved flow right after the procedure. You might have some pain or discomfort when urinating. You might see blood in the urine. There might be some pelvic pain associated with it. If those little implants aren't reabsorbed by the lining of the urethra and the bladder, you might get stones forming on them. That's pretty rare, but it does happen. And some patients have a little more frequency or urgency with the implants. So if I have patients that have those irritative symptoms that are more severe than their obstructive symptoms, such as they have worse urgency and frequency and less decreased flow, I usually don't think they're a good candidate for this. For both the UroLift and the Rezūm, your prostate size and shape do kind of matter on whether or not you're a candidate for these. So I do usually recommend getting a cystoscopy prior to these. We do the cystoscopy in the office. It lasts about 30 to 90 seconds. We just pop a scope in your bladder, look around the prostate, and then we get out. Most people tolerate it just fine. It's not something you look forward to. It's uncomfortable, but I wouldn't describe it as painful. But that way we know you're a good candidate, and I know this treatment's going to be good for you. If you have a really enlarged prostate where the prostate's growing up into the bladder, these don't work as well. Obviously, we can try them, see how you do, but I would probably recommend more the next 2 procedures. So GreenLight Laser Therapy and the Transurethral Resection of the prostate, I describe them as modalities where we're going in and we're removing prostate. One we're using a laser, one we're using a little knife. So I kind of say it's kind of like cutting bread. One time you're using a bread knife, another time you're using a steak knife. They're both serrated, but you know, it's kind of user's preference. The biggest advantage of GreenLight is that we can do it for patients that are on blood thinners. And there is some evidence out there that there's less bleeding with it. A lot of that evidence is based on the urologist. So there is studies out there that show that if a urologist does a lot of resections, there's less bleeding, and the same kind of bleeding with GreenLight. It is surgical outpatient procedure. So you come in that day, you can go home that day. If you don't want to go home that day, we can keep you overnight with a catheter. Everybody goes home with a catheter for 1 night. You do get general anesthesia for this. There's no permanent implant, and there's a 4.8% surgical retreatment through 5 years. Most GreenLights, I think, last 10 years. If they don't last as long, that's probably because we're not removing all of the tissue of the prostate and some grows back. There is some pain or discomfort when urinating post-operatively. You might have burning in the urine. You might have blood in the urine. You might not be able to pee right away. And with any of these, we could introduce a urinary tract infection, and you might experience some urgency and frequency afterwards. Most of my patients after the GreenLight, they get those scores way down below 10. So it does do a good job. There is a possibility of having what we call retrograde ejaculation. That's where you don't ejaculate when you orgasm, it just goes up into the bladder. I do think there's a little bit of an art to it, and most of my patients still ejaculate. They might just ejaculate a little less. And then here's a little video about the GreenLight laser. I'm just going to pop through. Here's what the laser looks like. It's a side-firing laser. As you can see, here's your bladder. There's the prostate. We have you in this position when we have you sleeping for the operating room. We put the cystoscope in, as you can see here, and then that laser fiber goes through the cystoscope, and then we start taking down the prostate tissue with vaporization. So here you can see the laser, it just vaporizes the tissue, much like this. And we just keep working. If anything, I don't like this procedure because it's kind of boring for me. But it's good for my patients who, like I said, are on blood thinners or have smaller prostates and who want to go home same day of the procedure. As you can see here, they've removed a lot of the tissue. There is still some tissue left, but now you've got this nice open urethra. We do destroy the prostatic urethral urothelium, like the lining, and you will have to heal that on your own. So that's where that burning comes into play. So that is that. Transurethral resection of the prostate. It's very similar to that video I just showed you, except for we're taking a hot wire and we're cauterizing and removing tissue. With the GreenLight, we're vaporizing tissue, so we won't have any pathologic sample. So if you have an elevated PSA, I usually recommend that we do the resection of the prostate because I can get prostate tissue and see if there's any cancer in it. We do tend to find cancer in 10% of patients who have the TURP. You get general anesthesia. There's no permanent implant. 5.8% surgical retreatment through 5 years, though most people, the TURP lasts 10 years. It is our gold standard, meaning that every other treatment has tried to measure up to it, and the GreenLight has come close. The main problems with it is you do stay in the hospital overnight. I actually do let people go home same day, but we have to do your first case and you spend most of the day in the recovery room. Most patients want to stay overnight. We take the catheter out and you pee in the morning. You might see blood in the urine. Of course, you might get an infection from the surgery. You might not be able to pee that day afterwards and you might need to go home with the catheter. And then the biggest side effect that people want to avoid is retrograde ejaculation, which is, again, when you orgasm, you don't ejaculate. With UroLift and Rezūm, people who want to preserve ejaculation, only 5% of guys have a problem with ejaculation after UroLift or Rezūm. With the TURP and the GreenLight, we usually see probably 25 to 50% of guys with ejaculatory problems. So it also kind of depends on how the urologist does it. Most of mine still ejaculate afterwards. It's just a little less than what they did before. The most invasive is the prostatectomy. It's a simple prostatectomy. So if you talk to your friends who've had prostate cancer and they've had their prostate removed, we're removing the whole prostate capsule and everything and re-sewing the bladder to the urethra. That's not what we're doing when you have BPH. When you have BPH, we cut you open. We actually open the bladder and open the capsule and we scoop the entire prostate out from the capsule and remove it. We don't do this as much anymore because there's a new laser treatment out there right now called laser enucleation of the prostate, and we kind of do it from the inside. I save this for people with very, very large prostates, where most of these procedures aren't even going to take care of, a third of the tissue. So people with 200-gram prostates or more, we're going and doing this because this is the fastest, easiest way to get them peeing well. The major side effect is bleeding. You might require a blood transfusion. If there's an infection there, you might get septic, and then most of people after this don't ejaculate. There is only a 2.7% surgical retreatment. So once we remove the prostate, if it's all out, there's nothing to regrow, you're probably not going to need another procedure. So insurance coverage. Rezūm and the newer ones take time to get insurance coverage. Lately, we haven't had many problems getting it covered by most insurance companies. Medicare covers it. I know that Blue Cross Blue Shield cover it, but it's up to the patient to contact their insurance provider. My office will do that for you to see if you're covered. We do know that a couple of the ones that don't cover it. But people are most of these insurance companies are coming on board because it is a recommended treatment by the American Urologic Association. So in summary, We've gone over the prostate, what it does, why it works, how it gets enlarged. We know that enlarged prostate means benign prostatic hyperplasia. We have these different treatment options, and we've gone through all of those. So what's the next step? If you think you're one of these people who has these bothersome symptoms or you're not tolerating your medication, we can talk about doing these minimally invasive therapies such as Rezūm or UroLift, or moving on to something a little more permanent, such as the GreenLight or the TURP. So you can come in and see me. We can talk about what treatment's best for you. Here are the references for this talk, and then here's a little bit of caveat saying that, you know, Rezūm, again, they've only studied it in patients with from 30 to 80 gram prostate. So if your prostate's very large, I might say, hey, if you want Rezūm, we can try it, but you might require 2 treatments, you know, a year apart. So we can kind of see where we've gotten it to go back. If you get regrowth, we can treat those spots. That's kind of why I like Rezūm. I do tell my patients that, like this, because BPH is such a big problem, there are lots of companies out there trying to make money. So that's why you see all those commercials and those ads in the newspaper. That's why these companies come up with these new and improved, easy and convenient ways for you to treat this. Some of these are going to fall by the wayside and they're not going to last. I think Rezūm has good staying power and UroLift has some staying power because I have seen patients do very well with them and have minimal complications. So that's why I offer it to my patients, because I do want you guys to have a more convenient, easy way to get rid of this lifestyle problem in your life. So I hope you learned something, and let's open it up to questions. Did we get any chat questions, Julie?
Awesome. Yes, we did. So we know we talked about kind of the average age for BPH. We have a question here. Can it happen as early as age 40?
Yes. I have had some patients in their 30s actually have this problem. So usually the younger you are, I do require scope because younger people have other problems that cause these. If we scope you and you've got a prostate that's encroaching on the urethra, then we can do these procedures. Those are the patients that I really recommend UroLift and Rezūm because it preserves that ejaculation. So since they're still young enough that they might want to father children naturally, might want to maintain ejaculation in their sex life, those are the patients that it's really good for, and I'm very glad we have that option.
Awesome. And then another one is, how soon after minimally invasive therapy like Rezūm or UroLift can you return to work, start exercising, resume a normal sex life, things like that?
Right, great question. So for UroLift, I usually say, well, for most of the treatments, I say no heavy lifting or strenuous exercise. That's for the TURP, the GreenLight, the UroLift, Rezūm for the first 3 days. So you just kind of want to take it easy those days, and that's mainly because of bleeding. After that, you can resume your normal activities. Most people with the TURP and the GreenLight take about a week off of work, and then they can go back. That's mainly because you're going to the bathroom pretty frequently and you might be irritated. So if you have a job where it's difficult to go to the bathroom every 15 minutes, then you might need to be staying at home. UroLift, I've had patients go back actually within a week. It just kind of depends on that urgency frequency and if you have a job where you can pee frequently. For the Rezūm, I tell people to usually take about a week off. Some people take longer if it's taking longer for those urgency and frequency symptoms to go away. I will say with the Rezūm that first 30 days, if you get 3 treatments on either side, the more treatments you get, the longer it takes for the body to resorb that tissue and the harder time you have recovering. So I have had patients get it and those first 30 days are pretty miserable and they can't work. I've had a lot of patients get 1 or 2 treatments on either side and they go back to work within the week. So it just kind of depends on how you tolerate the treatment and how your body is recovering. If you're somebody that recovers really well, you might be back as soon as 1 week. Most of the patients with Rezūm at 30 days are good to go. So most people are going back to work within a week or 2.
Great. Here's a good question. What are the implications of BPH for the health of your kidneys?
Great question. So if BPH is obstructing your bladder so much that your bladder is so full all the time that it's putting pressure on your kidneys, which drain down to the bladder, then you can get kidney failure over time. You have to have pretty severe BPH in order for that to happen. Most patients are seeing their primary care physicians and getting their kidney function checked every year. So that should be something we catch. Every once in a while, we get a patient who comes into the ER and their kidney function is horrible. They've tanked their kidneys and they need dialysis, and they realize their bladder is completely full and they haven't been emptying their bladder at all. But that's pretty rare. And those are people whose bladders have stopped functioning. So we try to catch the stuff beforehand. And the main thing that we check on that is the post-void residual. So if your post-void residual, where we scan your bladder after you pee with the ultrasound, is very high, like 500, 600, 700, that tells me that your bladder might not function anymore. And usually we'll get an ultrasound of your kidneys to make sure that we don't see your kidneys swelling with urine at that point. So most people, if they're draining their bladder and you're peeing, you know, you only have 200 left in your bladder after you pee, you're not putting any pressure on your kidneys, if that helps.
Awesome. Is there any guide or website that you can think of off the top of your head to show Kegel exercises, how to do them, and kind of the stuff you talked about during your presentation?
Not off the top of my head, but if you just go to Google and type in Kegel, K-E-G-E-L, or pelvic floor exercises, a bunch of websites will come up that describe it. We do have handouts in the office, so if you are one of my patients, next time you come, we can give you one of the handouts. Also, there is access to physical therapy, so if you have constipation problems or you don't think you're defecating correctly, and that's mixing with your urinary problems, then a lot of times I recommend just going to physical therapy for it. And the physical therapist can teach you how to do it, teach you the exercises, kind of go through things more in depth. It usually is about 4 to 6 visits once a week, and then you learn it all and you just practice it at home. So if you're interested in that, we can always refer you to an actual physical therapist to teach you. Otherwise, I would just put it in Google, type it up, and I bet you there'll be 10 websites from urologists, pelvic floor physical therapists. You know, I think Mayo Clinic has one, so you probably find it pretty easily.
Yeah, I just did a quick Google, and Mayo Clinic, WebMD, they all have options for you guys if you want to look that up after the fact. Okay, we've got one more here right now. As a first step, what test should I ask my primary doctor to run to see what stage my prostate enlargement problem is at?
I would just have them have you fill out, if you go to Google, you type in AUA symptom score, so AUASS, one of those symptom scores will pop up. You can go to Google Images or put in IPSS, those little tests that we had on the PowerPoint. And if you fill that out and it shows that your symptoms are moderate to severe, that's kind of a sign that we want to do something, because it really is affecting your quality of life probably. At the bottom of that questionnaire is a quality of life index asking you like how bothered are you? And if you're above mixed, if you're unhappy or dissatisfied, then I would say we need to do something. Your primary care doctor can start you on Flomax. That's usually my first line. Again, I usually like to talk to people about whether or not they're having majority urinary urgency and frequency as their main problem. So if you fill out that AUA symptom score and it's urgency and frequency as your 5s, and your flow is pretty good and you're emptying pretty well and you're not straining, then you might have an overactive bladder and you might need a bladder medication. So your primary care doctor can look at that score, kind of determine those things for you, start you on a medication. You can try that medication for 3 months, see if that score improves. And if it does, you can write it out on the medication. If the medication causes side effects and you don't like it, that's when you can say, hey, I don't like these side effects. Can you refer me to a urologist so I can get a procedure and therefore don't need to take the medication? Most of the patients I do these procedures on, we stop their medications. So we can get you off those pills. And that's also why a lot of people like to choose it, especially at a young age, because if you're 50 years old and you're starting on Flomax, are you going to take Flomax until you're 80 years old? It's 40 years on a pill versus just having a procedure and not having to take a pill. So if you're pretty young and you're starting on these medications, looking into seeing a urologist and seeing if there's a surgical intervention that'll work for you is probably a good idea. That's what I would do.
Awesome. Couple more funneling in. Can BPH cause urinary incontinence?
Well, I would say dribbling is one of the main incontinence issues with BPH. And what that is that you don't get enough flow to kind of empty the urethra. So if your flow is really low, it's just kind of trickling anyway, your urethra will hold urine. So when you're done peeing, you zip up your pants, you walk away, some of that urine still dribbles out. So that is one form of incontinence, which is leaking of urine. The other type of incontinence that it might cause is urgency or urgent continence, which is when you're rushing to the bathroom and you can't make it on time, or you're doing what we call the pincher, where you're just pinching the tip to kind of hold the urine in until you can get your pants down. Urinary urgency could be overactive bladder, but it could be severe BPH or long-term or chronic BPH. So those are the main two types of incontinence. The other incontinence is stress incontinence, where you leak when you laugh, cough, or sneeze. That's usually not a problem for men unless they've had a surgery on their prostate. And then the other one is overflow incontinence. And that's where people have those full bladders, they're backing up into their kidneys, and they're just constantly dripping urine out because it has nowhere else to go. And that would be somebody who's just constantly dripping all the time. So yes, it can. Any other questions?
There was, but I was on mute while I was asking it. One last question here. Okay, so for prostate cancer, similarly to BPH, what kind of tests should your PCP run for kind of first line defense against prostate cancer?
Right, so if your PCP is comfortable doing a digital rectal exam, that is one of the screening tests. It catches about 30% of prostate cancer, so it's not perfect, but it is something. And then they can get the PSA, which is the blood test. A while ago, there was a recommendation saying that we shouldn't do PSAs because it wasn't saving enough lives. However, the panel that decided that didn't have any urologists, no oncologists, which are cancer doctors, and no radiation oncologists, which are also cancer doctors on that panel. So there was, of course, a big uproar. We are saving lives by screening for prostate cancer, but we're trying to do a better job of picking out who to treat. So it's important that you know when you get your PSA checked, it might be elevated, and therefore you might need a biopsy or an MRI. So you might get 2 more doctor's visits for something that isn't a problem. So you could have an elevated PSA and now have prostate cancer. That's why it's a screening test. So we usually go over the risks of getting the screening test and what might happen to you by getting the screening test. So if you get a biopsy and you have a horrible infection from the biopsy and you don't even have cancer, that was one of the arguments saying we shouldn't screen. However, we think we're saving enough lives by screening. And that's because when you get prostate cancer, a lot of times you don't get symptoms until it's already in the bones. In the old days, the way we found prostate cancer was when somebody got a bone fracture, they would break their hip or their arm because they had tumor growing in their bone. And it's too late to treat the prostate cancer at that point. So by checking PSA levels, we're catching prostate cancers a lot earlier. And now we know how to do what we call risk stratification, where we decide, is this a low risk prostate cancer? And if you're 65 or 70 years old and you're only going to live 15 years and it's a low risk cancer, we might not even treat the cancer. If you have a high risk prostate cancer and you're 60 years old and you're going to live 20 to 25 years, then we better treat that cancer because it is going to make a difference in your life. So I highly recommend getting PSAs. The best way to watch PSA is to have a baseline and then get it either once a year or once every 3 years. If you have a family history of prostate cancer, you should be getting it once a year. If you don't have a family history and that PSA is less than 1.5, then your risk of having cancer in the next 3 years is virtually nothing. So you can just get it every 3 years. And that way, you're not going to get those false elevations. And the other thing I want to emphasize is that the PSA can be falsely elevated if you've had sex within 48 hours of the test. A lot of primary care physicians forget to tell you that. So make sure that if you're getting that blood test, you think back to yourself, did I orgasm in the last 2 days? Because if you did, you need to wait a couple of days in order to have what we would see as a normal level. But that's probably the best way to start screening, is just with a baseline PSA.
Awesome. Well, Dr. Lombardo, that is it for questions that we received here. I want to thank everyone for attending. The office will send out a follow-up email. If you have any questions you want to ask privately or schedule an appointment, there'll be an email and a phone number here. We actually have up on the slide here if you want to just call and make an appointment, you're free to do that. Dr. Lombardo, any final words, closing words?
I think most of you are already SLUCare patients. So if you want to MyChart message me any questions you have, that's fine. I do encourage most people with like, if you really want to talk to me about this as whether or not something you need, just to come to the clinic, because that way I can give you my full attention and full focus. Of course, here you can make an appointment at SLUCare Central. The 977-6610 number is specifically my Clayton office. We do have the brand new hospital and brand new ambulatory care center. So I do see patients over there, and it's a pretty fancy office, so you can come on over there. And that would be it. I hope you all stay well and sleep through the night. Stay healthy.